I show a quick carotid. A lot of this content is coming from our website, our YouTube. So if you go to YouTube to Lennox Hill Neurosurgery on YouTube and just click the videos, there's a ton of content there. And so if you want to go there, that's easy enough to do. I'll share my screen. So this is I've used the exoscope for really every surgery now. And we started using it for carotid surgery within the last couple of years. And I find it to be a really cool way of doing this operation. Just to go into a carotid endarterectomy is done when you have a narrowing of the carotid artery in your neck. And the reason why, depending on the severity of the narrowing, it increased the risk of stroke. There are basically patients who present with strokes, or what are called TIAs, which are transient ischemic attacks. And those are pre-stroke syndrome. If you present with an asymptomatic carotid stenosis, that's a little bit more tricky because sometimes you have to be careful. The risk of the procedure isn't higher than the risk of the natural history. You know, and a lot of what we do in neurosurgery, we're preventing problems. And so we always have to compare what the risk of leaving something alone is versus the risk of actual treatment. The risk of an endarterectomy actually is very low, but it turns out that the risk of just leaving a carotid alone, especially in women, is pretty low too. So we always have to balance all these different interests off. This was a 79-year-old male who actually presented with a stroke. A stroke is basically a brain injury due to a blood clot or a bleed. A blood clot in the artery or a bleed in the brain. And carotids present with strokes where little blood clots are in the vessels and they block arteries to the brain, which causes damage to the brain itself. They can be very small or very large. My father actually had a very large stroke when I was before medical school, and it was one of the reasons why I went into neurosurgery. Sometimes it'd be large like that, other times they're tiny little things. In this case, he had a acute left carotid occlusion. Was treated with an emergent aortic to left common carotid bypass on the other side. But that was how he presented. But during that care episode, he was found to have a right-sided asymptomatic carotid stenosis. And due to the fact that he'd had a prior stroke and had such a rocky course, we elected to go and treat it. What that looks like, if you look here, this is the right carotid. And you can see this is the common coming up. We're looking at the spine. These are the vertebral arteries within the neural foramen. There is no left carotid because he had a bypass because that presented with an occlusion. So you don't see that on this image. But here the common carotid artery has narrowing in it. You can see this kind of plaque that's sort of sticking into the vessel, this black stuff. And then it's tapering off and getting very narrow. I'll let this play. Had this asymptomatic right-sided lesion. So basically, next we can see a little higher up where how narrow that is. This is the common carotid. Here you can see the lumen of the artery is only from about there to there. This is the external carotid artery going to the face. So this is the internal carotid artery on its way up to the brain. And because of that severity of narrowing, we felt that it was in his interest to open that up and basically take that plaque out of there. That's the goal of the surgery. 80% plaque. By CTA. So you're seeing the right neck. The right neck. What that shows you is the incision. It's sort of like a hockey stick incision across the neck on the right side. The eye is up here. The feet are down this direction. So sort of the midline is about here. So this basically extends, and then the right ear is over here just to orient you. So this is the ear is over here. The incision extends behind the ear, and then across the neck. And you can see we're identifying what's a large facial vein. This is what's called the sternocleidomastoid muscle. This gives us entry into what's called near the carotid sheath. I'm putting my finger there around the sternocleidomastoid to mobilize it and get it out of the way, basically. This is what's called a monopolar. It's basically monopolar is the edge, prevents bleeding. And now I've got the sternocleidomastoid on retracted with a vessel loop. And now I'm just going to find the carotid artery. This is the common carotid. We see some little surgical clips on there to block little blood vessels. You can see the carotid artery pulsing. Now there's a retractor in here. I have the vessel. This is looped around the hypoglossal nerve. This nerve controls the movement of your tongue. And now I'm going to put some clips on little branches of the external carotid artery so they don't back bleed when I go to open up the vessel. But this is a typical way. You can see these are little vessel clips that I'm putting on there to occlude the artery. Talking to all the brain turns. Rafa was supposed to do it.
Dr. Ortiz is here right now.
Okay, yeah, no problem. I'll be done quickly. And here we're looping. So now I've got the external carotid artery vessel looped. This is the hypoglossal nerve vessel looped. And now we have to, in order to open an artery, you have to occlude it. So this is the common internal carotid artery being closed. Now I have the external carotid artery loop. I have the internal carotid artery closed. Now I'm going to put a clip on the common carotid artery. So now the entire vasculature is temporarily occluded. So once everything's closed, now I can open up the vessel. So we make what's called an arterotomy. This is super cool. And what you'll see here is the smooth normal wall, and then that area of plaque that we saw on that CTA, what I showed you earlier, and we go beyond the plaque into the internal carotid. You can see what that looks like, how it's almost, this is what cigarette smoke does. And now I'm gonna cut the plaque out. So you basically put a little dissector behind the wall of the artery and elevate that plaque from the inside of what's called the intima of the vessel, and then literally rotate that whole plaque and pull it out. You can see the extent of this. And this is why people have strokes. This is very degenerated and has all this loose material on it, and blood clots form on this and go to the brain. So here was elevating that plaque from the vessel wall. Look how beautiful that is, how it just comes out almost in one piece. The interesting thing is, in Rafael, I'm not sure if he's talking about that today, we can treat the same exact problem with stents, which are little tubes that cover this all up. And there it goes, there's the plaque. And now I've just got the normal wall now, and I can look, view the exoscope as I can angle it up the lumen and see inside the artery, and I can pull these little fragments of the vessel wall out. And now this is all, now we just have to close the artery. This is work vascular neurosurgeons do this, and neurosurgeons. It's one of my favorite operations to do, but unfortunately the vascular neurosurgeons in our hospital do the majority of these. It's just the way these cases get referred. And then we can just, now we're just going to close the artery with what's called proline. Proline is a type of synthetic suture, and these needles are what are called, these are 6-0 proline needle. The needle has a certain bend to it, and so we just run this stitch down the artery to close it. And I'll hustle up so Raf can get going. These are called locked sutures. Every suture we lock on itself. So now the whole thing is closed, and we've recirculated and we open up the artery. And then close the skin. And we put a drain in. This is the drain we usually leave inside underneath in case blood forms underneath the skin. This drain can drain a little excess blood, because one of the complications of this actually is a blood clot in the neck, which can compress the airway, those are my dogs. And that's it. And then you can see what that incision looks like at the end. This is actually an absorbable suture. The reason for showing this video is to show you everything, really a skin-to-skin video of you don't see this anywhere. Here's the drain coming out of the skin here, going to a little bag. And then this is the post-op CTA. You can see that vessel's wide open now. And you're tiny little narrowing, but nothing like there was before. This is a little bit narrow just from having vessel looped it and stenosing it. So I'll stop there. That's the typical carotid endarterectomy. I'll turn it over to Rafa, my best friend, and let him take over, because I know he has some cool stuff to show you guys.
Okay, thank you, David. Sorry for the delay. We were having some technical issues with the computer. That's
It's not a technical whiz like me, you know. You need.
I know. That surgery that David showed there is a life-saving surgery. It's a surgery that prevents a stroke and can save a life. Period. So in that sense, it's beautiful. He said that it was beautiful putting that ugly plaque out of the neck. I didn't think it was beautiful. If you were having breakfast or lunch or dinner, guys, I'm sorry you had to watch that. But yes, definitely it's a surgery that makes a huge impact. And like David mentioned, there are other types of ways of treating this, specifically stenting. I'm going to show you a case of a stent, not necessarily in an artery in the neck, but a little bit higher up in the artery, in the carotid artery. So let me share my screen.
If you want to share your screen, you need to do that. You'll be back in a second.
Okay, so
We'll be
we're
back
going
in
to
a
share
second.
now.
We'll be back in a second.
So guys, again, let me see if we can
One
show.
more thing. 30 seconds. Yeah.
I'll be back in a couple of seconds.
Okay, go to here. Yeah, you have to quit it. Yes.
Okay, we're back here. Let me see if I can share now.
All right. Yes.
Okay, Josh, can you see my screen?
Yep.
Okay. So this is the virtual neurovascular endovascular suite. And for the students following us, I have my Twitter feed and my LinkedIn name. And these are some of the hashtags that we're using just to raise awareness about this series that are educational, and obviously it's a way to connect with each other. So I'm going to show you a case of what's called balloon angioplasty, which is navigating a balloon from the artery in the leg. It's a long plastic tube, a catheter that has a little balloon at the end, and we put it in those areas that have narrowing inside the arteries in the neck or brain, and then we inflate the balloon to make the artery bigger. And then after that, we put in a stent that is permanent. The balloon is something temporary that we only inflate for a few seconds just to make the artery a little bit bigger. And then we put a stent all done through the artery of the leg without having to do an open neck or head surgery. So it's another way of achieving the result of what Dr. Langer was showing you in the previous video. This is a case of, this is a patient that presented with a stroke in the left side of the brain. That's the back of the head, that's the forehead, right side of the brain, left side of the brain is here. And these white areas, that's the stroke. This is called a diffusion weighted image MR that shows the regions of infarct. And that stroke was caused by that stroke was caused by narrowing. Oops.
is the case of
the left internal carotid artery, which is the artery that gives blood flow to the left side of the brain. So it corresponds to this area of infarction that you see. That's the area of severe narrowing. These are the arteries that give blood flow to the left side of the brain. So we do what's called a NOVA study that shows decreased flow on the left side compared to the right side. And then we follow that with an angiogram that again shows the severe narrowing in this picture. These, again, done going through the artery of the leg, the femoral artery, navigating a catheter inside the arteries. These are two different views of that artery. You can see how typically these arteries are completely straight and the catheters are straight. But in this case, the artery was very tortuous. And we had to use multiple catheters, one inside the other, so that we could have enough support to advance the catheter inside the artery. The closer we are to the problem that we're gonna treat, the safer it is, and the better we can be at achieving our goal of treating this narrowing. We measured the vessel, the normal vessel, 3.6 millimeters proximal to the narrowing. And then we measured distal to the area of stenosis, 4.28 millimeters. And then that's how we decide which type of stent we're gonna use. Here we have an entire team of people, a physician assistant, technologists, nurses, anesthesia, everybody working together, and we're preparing the balloon and the stent that we're gonna deploy. So we prepare the balloon on this table, inflate it just to make sure that it works before putting it inside the patient. And then we have the stent that we're gonna be deploying. We cross the area of narrowing with a wire. This is a lateral view. The patient's eye is here, top of the head is here, back of the head is here. And this is a frontal view, left side, top of the head, right side of the head is here. This is a balloon that is now being inflated inside the artery, inside the severe stenosis. The distal end of the balloon is here, that marker, and the proximal end is here. And you can see how now the balloon is inflating inside the narrowing. You can see here also in the lateral view. So this is what's called angioplasty. So now we're pushing plaque against the walls of the artery. So now the artery is a little bit bigger, and now we can fit the stent through that artery. We keep a wire all the time inside the normal arteries in the brain so that we can keep have good control and access to the lesion. Now you can see the stent going up. We're navigating the stent. We have different markers, these little black dots. Some are of the catheter where the stent is inside, and the other ones are of the actual stent. And now we're gonna deploy the stent. We're ready, we're in the position that we want to be, and we're unsheathing the stent. The stent is self-expanding, so it will start opening. You can see how it's opening, distal to the narrowing, and now it's gonna open here. Boom, now the stent is open. The stent is in place, and this is the final result. It doesn't have to be a perfect picture, and actually we don't want it to be a perfect picture because then we can have problems of injuring the wall of the artery and or causing bleeding in the brain. From too much blood flow all of a sudden. And we follow this patient by checking the NOVA that demonstrated significant increase in the blood flow on the left side. Before it was 110, now it's 230. So this was a great example of how we can treat narrowing of the arteries, whether it is in the neck, in the brain, or like this one that it is in the skull base region, as the artery goes inside the brain. Then I'm gonna show you other examples. I don't know, Josh, should we continue and then leave questions to the end?
Yep.
Okay, so this is another case, another video that I wanna show you something else that we do in neuroendovascular surgery. I know that Dr. Ellis has given previous presentations on intracranial hemorrhages. And this is an example of someone that did present with bleeding in the head, specifically in the left hemisphere. And you can see it's in the basal ganglia on the left side of the brain. It's a deep type of hemorrhage that the patient presented with complete paralysis of the right side of the body and inability to speak or understand others, aphasia. So that was a CAT scan, and this is what's called a CTA, a CAT scan with contrast, that suggests that there's some abnormality here on the left side that you're not seeing on the other side. And because of that, we took him to the angio suite, and again, navigating a catheter from the artery of the leg, and we inject contrast in the artery, in the carotid artery, that does show that there is a pathology and abnormality that can predispose someone to have that type of bleeding. And it's an abnormal connection between artery and vein that should not exist, an AVM. This is what's called the AVM nidus, which is the connection between arteries and veins. And we are going to go ahead and treat this by endovascular embolization, by closing, sealing those connections between arteries and veins to prevent bleeding again in the future. We're navigating a catheter, again, from the artery in the leg. We went all the way into the skull base region. And now we will put another catheter inside that one, all the way into the AVM itself and into the feeder to the AVM. This is a lateral view. This is an AP view, a frontal view of the same. And this is the feeder, the artery that goes to the abnormal connection between artery and vein. This is the artery that goes to the normal connection between artery and vein. That corresponds with this that we saw lower down. Now we inject contrast inside that artery to demonstrate that we are in a safe position for us to close that artery and connection between artery and vein. If that artery was supplying normal brain, it wouldn't be a safe position. But in this case, we need to get as close as possible so that the embolic agent that we're gonna inject, which is glue and BCA, can penetrate into the abnormal connection. And this is the moment where we're injecting the glue. We see stagnation of contrast into the AVM, suggesting that there is an unstable situation, that there is a risk of rehemorrhage, of the patient bleeding again from this. Again, you can see the stagnation of the contrast. When we inject the glue, the NBCA mixture, it's literally crazy glue. It's N-butyl cyanoacrylates. It's cyanoacrylate is the same chemical composition of crazy glue. It's just that this is a medical type of crazy glue, and we mix it with ethiodol or lipiodol that makes it less sticky, the glue, and allows us to be able to observe the glue as we're injecting it. You can see this is the syringe in which I have the mixture of the glue and the ethiol, and this is Guillermo, physician assistant, that he's ready, because when I'm injecting the glue, I'm gonna tell him to pull the catheter right away. We have seconds, right? We injected the glue, and I tell Guillermo, pull, and boom, he pulls the catheter out. If we leave that catheter there for longer than that amount of time, the catheter would have gotten stuck, like any crazy glue would do with any object that you try to glue. So after that injection, we see that there was diminishing flow into the malformation, into the AVM, but there was still residual. So now we need to go ahead and do the same thing again. We need to go for the other one so that we can continue to decrease the amount of blood that is going into that connection between arteries and veins. You can see we're navigating another catheter. That first catheter that we use for the glue, that we throw away, because that already is filled with glue inside. So we had to throw that away and start again from zero, going from the leg again, going into the artery that is supplying the AVM. We do mapping of these arteries. And for example, from this injection, we noticed that there was normal and abnormal supply. So we had to go even closer to the AVM, to the abnormal connection between artery and vein, so that we avoid injecting glue into the normal artery. If we inject glue in the normal artery, the patient will have a stroke. The other risk factor or risk of this type of procedure is if we inject the glue and it goes into the vein side instead of into the connection between artery and vein, then you close the outflow and there's blood coming in, has nowhere to go out, and causes bleeding. So you saw that was us preparing the glue mixture again. You can see I am agitating the mixture of ethiol, NBCA, and something called tantalum. Tantalum is a metal powder that we also use to coat the glue and the ethiol mixture so that we have better visibility on the X-ray. If we inject glue by itself, you're not gonna see it on the X-ray. Ethiol with the glue, you see on the X-ray. However, we're into very tiny, tiny vessels here. One of the smaller arteries that we can have access to at the time of navigating a catheter inside the arteries. This was a lateral lenticular striate in the first injection, coming off the M1 segment of the left metacerebral artery. And now we're in the anterior choroidal artery, which is a very important artery of the brain that controls vision, controls strength on the opposite side of the body. So it is critical that we're as accurate as possible in the injection of glue, and that's why the visibility is so important for us. In endovascular, we say we're as good as what we see, and this is a great example of that. We always work at least 2 people at the same time. 4 eyes see more than 2, and what we do is nobody can be looking at both of these monitors at the same time. So one person concentrates in looking at one monitor, the other person concentrates in looking at the other monitor. And we know where we're expecting this glue to navigate based on the injection of contrast that we see before, that we saw before. So if we see that when we're injecting the glue, it goes somewhere else, whether it's coming back in the catheter or going into another artery, then we need to stop. This is that other injection. This is how we pull the catheter again very quickly. And that's the amount of glue that we inject here. The amount of mixture is 0.2 milliliters. 0.2 milliliters per injection. So very small amount. So by doing this, we significantly decrease the flow into the arteriovenous malformation. There was still a little bit of supply, or what we call indirect supply, from a small branch, again, another lateral lenticular striate. We did attempt to safely catheterize that other vessel that was supplying it, the lateral lenticular striate, but because of the anatomy of the vessel and the tortuous shape of and the acute angle of the vessel, it was not feasible for us to get too close to the arteriovenous malformation nidus. And we had to keep the catheter too proximal. When we don't have a position in which we can achieve a safe position for us to embolize and close the artery safely without significant risk, then we do not put that patient at risk. And we do not go ahead and close the AVM. And however, we knew that by significantly decreasing the amount of blood flow, the patient is in a safer position. And not only that, remember that little stagnation or bubble that was keeping some contrast inside, for a lingering contrast inside, that was a pseudoaneurysm or aneurysm that is very unstable and can cause bleeding. In that case, we closed that. That was most likely the source of the bleeding. You can see here the tortuous anatomy of the vessel. It was not feasible for us to make, we had made multiple curves down below. It was not possible for us to keep navigating to a closer position. So at the end, again, we had a very small amount of FABM. We thought that it was safer to stop. However, because of the significant decrease in the amount of blood flow that we created, look at this. In the follow-up, the malformation went away completely. So this is the follow-up angiogram 3 months later, and he's cured from the arterial malformation. He also had a great clinical recovery. And I will show you one more quick case, and then I open the forum for questions. This is something else that we perform. This is a little bit different from the other types of cases. The first one was a procedure to prevent strokes from happening, which can be, strokes can be lethal. 30 to 40% of people that have a stroke die from the stroke. Whether it's ischemic or hemorrhagic. The first one was an ischemic stroke. The second one was a hemorrhagic stroke. So both of those cases are put the patient at risk of death. And that's why we treat them. In this case, I'm gonna show you something that is benign, something that will not predispose someone to mortality. However, it can predispose someone to symptoms. And this is what's called a lymphatic malformation. It's a vascular malformation that is congenital. People are born with vascular malformations in different parts of the body. They're more common in the head and neck region than anywhere else in the body. And in this specific case, this is someone that has an orbital lymphatic malformation. You can see the left eye, the right eye, this is her brain. And these are two different cuts of the same, showing the vascular malformation and showing here two different colors inside the malformation. You see the white and the gray. And so that line is what we call a fluid level of what happened to this girl who was born with this but didn't present until later in life, is because she had bleeding inside the malformation. So that layering is lymphatic fluid on top and a collection of blood underneath. And what we do is called sclerotherapy, which is injecting something to injure that cavity, that cyst. We use image guidance so that we avoid hitting the eyeball. We put a needle inside the orbit, inside the cyst, filled with lymphatic fluid and blood. We drain as much as we can drain safely, and then we go ahead and infuse the sclerosing agents. So you can see we are putting a needle right now in her orbit, right next to her eyeball. We will, and as I mentioned before, we do this under image guidance, as you saw in the previous pictures. So we know exactly where we need to go to prevent injuring the eye or getting too deep and going potentially and injuring some nerves. So what the sclerosing agent does is that it injures the cavity, the wall of that cyst, and prevents it from growing again. When it injures it, it creates a little, the cyst seals because the walls collapse with each other. We can use different types of agents for this type of procedure. In this case, we use something called bleomycin, which is an antibiotic that has been used as a chemotherapy agent for decades. And for the past 15 years, we have been using it for this type of vascular malformations. Because we're injecting in the orbits, we don't have too much space. And the main reason for treating this is to allow for her to have normal vision, normal motion, motility, and movement of the eyes. So we, if this untreated, she could potentially end up with some vision loss as well as double vision, because one eye is not moving as good as the other one, so there's this conjugate gaze. The material or the substance that we're injecting here is not as toxic as others. In some instances, we inject alcohol or something called doxycycline, which is another antibiotic, but both of those are more toxic than bleomycin. And because we're working in the orbit, we don't want too much swelling. One of the risks of this procedure is that if you inject too much of the, or infuse too much of the substance, there can be a lot of swelling behind the eye. And then that's an emergency. You need to perform an incision next to the eye to allow for the pressure to come out. So we just infuse approximately 1 milliliter, 1 cc, but that's approximately 3 milligrams of bleomycin, and that's enough for this procedure and allows for the malformation to heal. You can see that with just one treatment, the lesion regressed and became significantly smaller. Some people do need a retouch. Actually, most people do need 2 to 3 sessions of this type of treatment. In her case, we did 1, and we are still monitoring. In the first picture, you saw how her eye was protruding forward. She had proptosis. Now they're aligned, and she does not have any double vision, and her vision is normal. So this is someone that will need follow-ups throughout her life. As I said before, this is a benign condition, so our goal is not necessarily a cure, but more of controlling symptoms, allowing for normal vision, allowing for a normal growth. These type of lesions sometimes happen in the tongue, and we need to treat them because they prevent normal swallowing or trouble breathing. We also, some people have them in the maxilla or mandibula, and those we need to treat because if we don't treat them when they're as a child, they will have abnormal growth of their teeth and have a lot of orthodontics problems and abnormal growth of the maxillofacial structures and bones. So again, like we have mentioned throughout this series, this is all about team. For us to be able to do this the right way, we need to work together, complement each other, and it's one of the most beautiful parts of what I do for a living. It's having the privilege of working with people that I respect, that I trust, and I know that they feel the same about me. So by having this chance to work with people that you respect and trust, you have an opportunity to really do extraordinary things. So I think that's it for my presentation of cases. So Josh, if you want to go ahead and open this forum for questions.
Just opened it.
Okay, so I see many coming in. How often do you see cases with moyamoya disease, and what is the usual surgical procedure? I don't know if Dr. Langer is still connected, but Dr. Langer is a world authority on moyamoya disease, so we do get a significant number of patients referred to us with this type of problem. Moyamoya, for people that don't know, is progressive narrowing of arteries in the circle of Willis, so the major arteries in the brain, most of the time in the anterior circulation, the arteries that supply the front part of the brain. And it can get to a degree where it becomes completely blocked, completely occluded. And these patients can be predisposed to strokes, whether it's ischemic or hemorrhagic. And the surgical procedure is cerebral bypass. We need to do an entire workup for these patients to determine if the bypass is indicated because of multiple reasons. Number one, we need to determine if this patient is in fact having moyamoya, or is it something else? Or is the narrowing of the arteries caused by something else? And if it is caused by this idiopathic or unknown cause for narrowing, not necessarily hardening of the arteries, not from atherosclerotic disease or from other inflammatory conditions, and then the bypass is indicated after a complete workup determining the need for it. And that's connecting arteries that go typically outside the brain, that can go to the scalp region, and connecting them with an arteries that go inside the brain. What dangers associated with contrast use with angiograms? Anything we do carries some risk. Anything doctors do carries a risk. However, angiograms are very benign procedures. The contrast that we use is the same one that is used for a CAT scan. Some people have allergies to this contrast. Is the minority of the people. And obviously, if someone has any, is prone to allergies to shellfish, we usually pre-medicate them because this is a contrast based on iodine. Pre-medication is with Benadryl and steroids before the procedure and during the procedure. So we're usually able to prevent any significant complication from this. If someone has significant kidney failure or problems with renal failure or problem with the kidneys, the contrast can be risky because it can dehydrate the person and cause more trouble with the kidney. So that's something that is very important for us to know ahead of time, and so that we can hydrate the patients and avoid a complication with the kidneys. What are your thoughts of gamma knife surgery for AVM treatment? So brain AVMs can be treated, can be monitored without treatment if they have never caused bleeding in the brain. When they cause bleeding in the brain, then we definitely recommend treatment. And whether it is embolization or resection surgery or radiation, gamma knife is a type of radiation for AVMs. It is effective for the ideal type of AVM. Every AVM is different. Every size of AVM is different. Every location of AVM is different. So depending on the size, location, history of bleeding, and risk factors for bleeding and age of the patient, that's how we determine what should be the appropriate management, either following them, surgery, endovascular embolization, or radiation. Sometimes we do a combination of those treatments. Most commonly, if someone had bleeding in the past, we try to cure it as soon as possible, whether it is with surgery, embolization alone, or both, a combination. Sometimes we use embolization to decrease the flow into the AVM and following it by surgery. When someone bleeds, we try to avoid doing the radiation treatments because they usually take longer to be effective and to cure the AVM. The surgery and or embolization can cure them right away. Radiation usually takes 2 to 3 years to see the final results. And so if someone had an unstable AVM that already bled, we're afraid of just treating with radiation. We don't think it's appropriate. But again, for the right patient, we definitely recommend it depending on the location. Is it possible to use suction to remove plaque formed in an artery? Would a stent be a better option, and why? In acute stroke settings, whenever someone is having a stroke that happened within 24 hours and that they haven't had a complete infarction in the brain, we're performing what's called mechanical thrombectomy, in which we navigate catheters and do one of those treatments, either putting a catheter to aspirate and suction the clot out, or put a stent that pulls the clot out. Is what's called a stent retriever, which is a temporary stent just so that the clot gets tangled in the vessel and then pull it out. That's the only role that we're using today for aspiration in the acute stroke setting. When we're treating someone with a stent or endarterectomy, is usually someone that doesn't need an emergency life-saving procedure at that second. And those patients We haven't found that using aspiration is recommended, but we do treat them with a balloon angioplasty and stenting like I showed before, or with endarterectomy for the carotid artery like Dr. Lange showed earlier. How would you treat a cavernoma? Cavernoma, for people that don't know, these are usually congenital vascular malformations, which are can carry a risk of bleeding inside the malformation. This is like a birthmark. Like some people have birthmarks in the skin, some people have birthmarks in the brain. So a cavernoma is like a birthmark. If the cavernoma is asymptomatic, if it's not causing any problems to the person, we usually just follow them. If that cavernoma is predisposing someone to have seizures, then yes, it's recommended to do surgery and resect them if it is in a safe and a location in the brain for the surgery. Also, if that person is having repeat hemorrhages, as I mentioned, these cavernomas can bleed inside the malformation. So if they bleed, they can cause some swelling in the brain, and the person can develop some symptoms of weakness, paralysis, but they usually do get better as that swelling resolves and the bleeding resolves. If it's in a location that is safe for surgery, we recommend surgery. If it's in a location that is very tricky or dangerous for surgery, then we usually continue to observe, and if they keep having repeated hemorrhages that predispose them to worsening symptoms, that's when we proceed. Are the stents drug-eluting for the brain and for the carotids? Right now, we are not using drug-eluting stents. I know that in the cardiology literature, they have been very promising, but in the brain and cervical literature and the neck, they are not as effective. They haven't been demonstrated to be as effective. What do you know if there is an unexpected blockage of an artery while putting in the catheter? Do you find another pathway? So, correct. That's rare. Usually we do have a study ahead of time from which we determine if it is safe to navigate catheters inside the artery. So it's rare that we would be surprised and then not being able to navigate through the artery, the intended artery. But yes, for example, if there's a blockage in our artery in the leg, we go from the artery in the arm. If there's a blockage in the artery of the leg and the arm, you can go through an artery in the neck to get to the pathology that we're trying to get to. Is it possible to undo the gluing in case it gets into the vein that you mentioned? No. This is an irreversible. Maybe that's a great project if you can work in a glue that you can dissolve after it is injected in case it's not in the right place. But today that hasn't been created. So until today, whatever we inject, that's permanent. When doing the angioplasty, is there a net to catch any plaque that may break off during the procedure? The answer is yes. We use what's called a distal protection device, which is like a little umbrella that we navigate inside the artery and goes first. We park it in this specifically when we're doing a treatment for the carotid artery, for the neck. When we're treating the brain, we don't have that luxury. That doesn't exist. But when we're treating the neck, we park a little umbrella that goes in the skull base, and anything that we're doing in the artery in the neck, in the balloon angioplasty, is lower down, or the stent is lower down. So if there's a little plaque that gets dislodged, it gets caught in the umbrella or filter, and then we pull the filter out at the end of the procedure. What is the catheter made of? We have different types of catheters. These are what's called hydrophilic catheters. Right now, many metals are being used and being braided to create different proximal stiffness with distal softness of the catheter. Could you further delineate our radiology of AVM? Again, AVM, connection between artery and vein, that should not exist. And every AVM is different, so we need to analyze based on MRI, based on angiogram, based on CTA, CAT scan, an MRA. We need to determine which are the arteries feeding it, which are the veins draining it. Every AVM is completely different, and we can have AVMs in the entire body. So, so even within the brain, and there are different sizes, and they can be in different locations, and obviously supplied by different arteries or drained by different veins. Can quickly removing the catheter present any risk damage to the artery walls? We have not seen a significant problem unless the catheter gets glued. If it gets glued and you pull it too quickly, you can cause a hemorrhage, you can cause bleeding. What do you use if the bleeding is way too much and it cannot be stopped by glue alone? The bleeding, the glue that we use is to prevent another bleeding from happening. Whenever we do an angiogram or a CAT scan, if we see blood, it doesn't mean that the patient is actively bleeding. It means that it bled at some point. Nobody would tolerate active bleeding for minutes. So it's a 1 second thing that happens, and that's the end result of that bleed. So anytime we treat is to prevent another bleed. Does the amount of bleomycin depend on the size of the tumor? Yes. The larger the malformation, the more requirement of bleomycin it has. Having said that, we have a limit of how much we can use, because if we surpass a lifetime dose of 300 milligrams of bleomycin, we can predispose the person to pulmonary fibrosis or injury to the lungs. That's why for this type of procedure, we only use 15 milligrams. So even if we do 20 procedures, it will not be affected. How to treat vascular malformations elsewhere beside the eyes? We treat them the same way, doing sclerotherapy or resection with surgery. When inserting a catheter from the leg, how do you guide it all the way to the right vessel? Experience. And that's, we put wires inside, and we have expectations of what the normal anatomy is. Sometimes we get surprised and we need to adapt, but that's why experience comes into play. So you know all the variations that different people have. In your opinion, how much training is required to master the usage of a catheter? Many years of doing it the right way. I have Guillermo works with me. He says some people make mistakes for 20 years and call it experience. In reality, we do need many years of training with the right person and doing it the right way. How many years? It depends, 5, 10, 15, 20, 25, depending on the amount of cases that you're doing. How long do these surgeries take? Anywhere from 1 hour to a 5-hour procedure is the average. I think we're running out of time.
Yep.
Okay.
Thank you so much, Dr. Ortiz.
Sure. Again, hopefully people learn something from this, and like I showed at the beginning, you can reach out to me on Twitter or LinkedIn, and hope to hear from all of you. Thank you for this opportunity.
Have a great day.
Bye.